Surgical nutrition. Questions and answers. Welcome to today's episode of our Surgical Education Podcast, where we dive deep into the essentials of surgical nutrition. We will be following a formal question and answer format, perfect for resident-level revision. Pause the video after each question to attempt answer. Let's get started. Section 1. Fundamentals and Assessment Question. What are the two primary goals of nutritional support in surgical patients? Answer. The goals are to prevent or correct nutrient deficiencies and to modulate the metabolic response to stress, aiming to improve clinical outcomes such as reducing complications, length of stay, and mortality. Question. What is the difference between starvation and stress metabolism? Answer. Starvation is adaptive, where the body slows metabolism and uses fat stores for energy, preserving lean body mass. Stress metabolism, seen during injury or surgery, is maladaptive. Hormones such as cortisol and catecholamines cause hypermetabolism, insulin resistance, and rapid breakdown of lean body mass for glucose production. Question. Name the three macronutrients. Answer. Carbohydrates, proteins, and fats. Question. What is the primary goal of protein provision in the stressed patient? Answer. The main goal is to provide substrates for acute phase protein synthesis, wound healing, immune function, and to reduce the loss of lean body mass. Providing energy is not the primary aim. Question. How is energy measured? What are the units? Answer. Energy is measured in calories or kilocalories. The international standard is kilojoule. 1 kilocalorie equals 4.184 kilojoules. Question. What is basal metabolic rate? Answer. Basal metabolic rate refers to the energy expended by the body at complete rest, in a thermoneutral environment, and in the post-absorptive state, which means after fasting for 12 hours. It reflects the energy needed for basic physiological functions. Question. What is resting energy expenditure? Answer. Resting energy expenditure is similar to basal metabolic rate but measured under less restrictive conditions. The terms are often used interchangeably in clinical practice. Question. What is the most accurate method to measure energy expenditure? Answer. The most accurate method is indirect calorimetry, which measures oxygen consumption and carbon dioxide production. Question. What is the Harris-Benedict equation? Answer. It is a classic equation to estimate basal metabolic rate based on weight, height, age, and sex. This estimation is often multiplied by a stress factor to compute total needs. Question. What is a quick, common weight-based calculation for estimating energy needs in non-obese, hospitalized patients? Answer. 25 to 30 kilocalories per kilogram per day. Question. What is a quick, common weight-based calculation for estimating protein needs in a stressed surgical patient? Answer. 1.5 to 2 grams per kilogram per day, compared to 0.8 grams per kilogram for a healthy adult. Question. What is the most visceral protein marker and best indicator of nutritional status? Answer. Albumin is the most commonly measured but has a long half-life and is affected by inflammation and fluid status. Prealbumin, also called transthyretin, has a shorter half-life of 2 to 3 days and provides a more sensitive marker of short-term changes but is also influenced by inflammation. Question. What is subjective global assessment? Answer. Subjective global assessment is a clinical tool that includes history and physical exam to classify patients as well-nourished, moderately malnourished, or severely malnourished. Question. What is the Nutritional Risk Screening 2002? Answer. The Nutritional Risk Screening 2002 is a validated tool to identify hospitalized patients at nutritional risk based on impaired nutritional status and severity of disease. Question. What is the most common electrolyte disturbance when initiating nutrition support? Answer. Hypophosphatemia, which occurs as part of refeeding syndrome. Section 2. Malnutrition and micronutrients. Question. Define malnutrition in the clinical context. Answer. Malnutrition is a state of nutrition in which a deficiency, excess, or imbalance of energy, protein, and other nutrients causes adverse effects on tissue and body form, function, and clinical outcomes. Question. What is the difference between marasmus and kwashiorkor? Answer. Marasmus is chronic energy deficiency resulting in generalized wasting, while kwashiorkor is acute protein deficiency despite adequate calories, leading to edema, ascites, and fatty liver. Hospitalized patients often have a mixed picture. Question. Why is zinc important for surgical patients? Answer. Zinc is a cofactor for DNA and RNA polymerases and is crucial for protein synthesis, wound healing, and immune function. Question. Why is vitamin C important for surgical patients? Answer. Vitamin C is needed for the hydroxylation of proline and lysine in collagen synthesis, and is thus critical for wound healing. Question. What trace element deficiency is associated with glucose intolerance? Answer. Chromium deficiency. Question. What vitamin is a cofactor for carboxylation reactions in coagulation factors? Answer. Vitamin K. Question. What is the most common nutritional deficiency worldwide? Answer. Iron deficiency. Question. What fat-soluble vitamins can become deficient in patients with fat malabsorption? Answer. Vitamins A, D, E, and K. Question. What is the role of glutamine? Answer. Glutamine is a conditionally essential amino acid during stress. It is a primary fuel source for enterocytes and immune cells, helping to maintain gut barrier function and immune response. Question. What are omega-3 fatty acids and why are they important? Answer. Omega-3 fatty acids, such as eicosapentaenoic acid and docosahexaenoic acid, are polyunsaturated fats found in fish oil. They have anti-inflammatory and immunomodulatory properties. Section 3. Enteral nutrition. Question. What is the primary advantage of enteral nutrition over parenteral nutrition? Answer. Enteral nutrition maintains gut barrier function, prevents bacterial translocation, reduces infectious complications, and is more physiological, safer, and less expensive. Question. What is the gold standard for nutrition support access? Answer. The gastrointestinal tract. If it works, it should be used. Question. What does the acronym SPICE stand for in relation to feeding tube placement? Answer. Suspicion of incorrect placement, patient condition change, injection of anything, cuff check if tracheostomy, and enteral feeding system change. It is a reminder to verify tube placement before use. Question. How do you confirm placement of a nasogastric or orogastric tube? Answer. Radiographic confirmation is the gold standard before initial use. pH testing of aspirate is a common bedside method but is less reliable in some circumstances. Question. What is the difference between a gastric and a post-pyloric feeding tube? Answer. Gastric tubes end in the stomach and allow for bolus feeding. Post-pyloric tubes end in the duodenum or jejunum, requiring continuous infusion and are used for patients with certain risks. Question. When should a post-pyloric tube be considered? Answer. In patients with gastroparesis, recurrent vomiting, severe reflux, or a high risk of aspiration. Question. What is the starting rate for most continuous enteral feeds? Answer. 20 to 30 milliliters per hour. Advancing as tolerated. Question. What is gastric residual volume? Answer. The volume of fluid aspirated from a gastric feeding tube before feeding. Question. What is a high gastric residual volume that should prompt attention? Answer. Greater than 500 milliliters, or persistently elevated volumes with other signs of feeding intolerance. Question. What are common signs of enteral feeding intolerance? Answer. Nausea, vomiting, abdominal distension or pain, high gastric residual volume, and diarrhea. Question. How should diarrhea in a tube-fed patient be evaluated? Answer. Diarrhea should not be automatically blamed on the formula. Other causes, such as infection, medications, or impaction, should be considered first. Question. What is refeeding syndrome? Answer. Refeeding syndrome refers to potentially fatal shifts in fluids and electrolytes in severely malnourished patients starting nutrition. It is characterized by hypophosphatemia, hypokalemia, hypomagnesemia, and fluid overload. Question. How can refeeding syndrome be prevented? Answer. Identify at-risk patients, start nutrition slowly, monitor and correct electrolytes, and avoid overfeeding. Question. What is the role of immune-modulating formulas? Answer. These formulas contain ingredients such as arginine, omega-3 fatty acids, and nucleotides. They are used in select populations to reduce infections and length of stay. Question. When is a peptide-based, or semi-elemental, formula indicated? Answer. For patients with impaired digestion or absorption, such as in pancreatitis or short bowel syndrome. Section 4. Parenteral nutrition. Question. What is the primary indication for parenteral nutrition? Answer. When the gastrointestinal tract is non-functional, inaccessible, or unable to meet requirements for a prolonged period. Question. What are the major risks of parenteral nutrition? Answer. Catheter-related bloodstream infection, metabolic complications such as hyperglycemia, refeeding syndrome, and liver disease, as well as gut mucosal atrophy. Question. What are the three main macronutrient components of parenteral nutrition? Answer. Dextrose, amino acids, and intravenous lipid emulsion. Question. What is the maximum glucose infusion rate to avoid hyperglycemia? Answer. 4 to 5 mg per kilogram per minute. Question. Why are intravenous lipid emulsions included in parenteral nutrition? Answer. They provide concentrated calories, essential fatty acids, and decrease the osmolality of the solution. Question. How often should blood glucose be monitored in a patient starting parenteral nutrition? Answer. Every 4 to 6 hours until stable, then at least daily. Question. What is a common strategy for managing hyperglycemia in parenteral nutrition? Answer. Adding regular insulin directly to the nutrition bag and using a separate subcutaneous insulin sliding scale. Question. What is parenteral nutrition-associated liver disease? Answer. It is a spectrum of liver dysfunction, ranging from fatty liver to cirrhosis, caused by long-term parenteral nutrition. Question. What is the difference of a central line versus a peripheral line for parenteral nutrition? Answer. Central parenteral nutrition is hyperosmolar and must be delivered via a large central vein. Peripheral parenteral nutrition is less osmolar and can be given via a peripheral vein, but is less calorically dense. Question. How is the osmolality of parenteral nutrition estimated? Answer. It is calculated by specific formulas based on concentrations of amino acids and dextrose, with peripheral nutrition kept under 900 milliosmoles per liter. Question. What does cycling parenteral nutrition mean? Answer. Infusing the total daily volume over a shorter period, rather than continuously, to mimic normal feeding and potentially reduce complications. Question. What is the most serious immediate complication of central line placement for parenteral nutrition? Answer. Pneumothorax. Section 5. Special situations and disease states. Question. What are the nutritional priorities in a burn patient? Answer. Burn patients have extremely high caloric and protein needs due to hypermetabolism and catabolism. Early enteral nutrition is critical. Question. How does nutrition management differ in acute pancreatitis? Answer. Early enteral nutrition via a post-caloric tube is not recommended to maintain gut integrity and reduce complications. Question. What is an enterocutaneous fistula? Answer. It is an abnormal connection between the intestine and the skin. Question. What is the primary nutritional strategy for a high-output enterocutaneous fistula? Answer. Bowel rest with nothing by mouth, use of parenteral nutrition, and selective use of specialized enteral nutrition. Question. What is short bowel syndrome? Answer. A condition from significant resection of the intestine, causing malabsorption, diarrhea, and deficiencies. Question. What is the role of glucagon-like peptide 2 analogs in short bowel syndrome? Answer. They promote mucosal growth and can reduce the need for parenteral nutrition. Question. What dietary modifications are needed after a gastrectomy? Answer. Small and frequent meals, limiting simple sugars, high protein and fat, and separating liquids and solids to avoid dumping syndrome. Question. What is dumping syndrome? Answer. Rapid gastric emptying leads to symptoms such as sweating, tachycardia, cramping, and diarrhea. Question. Why are patients with liver failure at risk for malnutrition? Answer. Due to poor intake, malabsorption, altered metabolism, and increased protein catabolism. Question. What is the concern with protein in patients with hepatic encephalopathy? Answer. Traditional teaching restricted protein, but current guidelines recommend standard protein provision to preserve muscle and support ammonia detoxification. Question. How do nutritional needs change in acute kidney injury on continuous renal replacement therapy? Answer. There are significant losses of nutrients, so protein needs are very high, and electrolytes must be closely monitored and replaced. Question. Why are patients with end-stage renal disease on hemodialysis different? Answer. They have fluid and electrolyte restrictions, and moderate protein needs to replace dialytic losses but avoid excess urea. Question. What is the nutritional strategy for a patient with a traumatic brain injury? Answer. Early enteral nutrition is beneficial due to severe hypermetabolism and catabolism, with prokinetic agents often required. Question. What is the role of probiotics in surgical patients? Answer. The evidence is mixed. Probiotics may reduce some infections but are not standard of care for all patients. Question. How should a patient be nourished in the immediate perioperative period? Answer. Enhanced recovery after surgery protocols encourage clear carbohydrates before surgery, avoiding prolonged fasting, and early resumption of oral intake. Question. What is the role of chewing gum in postoperative patients? Answer. Chewing gum stimulates the vagal response, which may promote the return of bowel function. Question. What are medical foods for inborn errors of metabolism? Answer. Specially designed formulas low in particular amino acids, vital for life and must be continued perioperatively. Question. Why is nutrition important in oncology patients? Answer. Cancer cachexia is common, and preoperative nutritional optimization can improve surgical outcomes. Section 6. Complications and monitoring. Question. What is the most common complication of tube feeding? Answer. Diarrhea. Question. What is the most serious complication of central venous access for parenteral nutrition? Answer. Catheter-related bloodstream infection. Question. How is a suspected catheter-related bloodstream infection managed? Answer. Draw blood cultures, start broad-spectrum antibiotics, and often remove the catheter if certain pathogens are identified or the patient is septic. Question. What is transaminitis in a patient on parenteral nutrition likely due to? Answer. Fatty liver from overfeeding, especially with excess carbohydrate calories. Question. What is cholestasis in a patient on long-term parenteral nutrition likely due to? Answer. Lack of enteral stimulation, leading to biliary stasis. Question. What electrolyte abnormalities are common in refeeding syndrome? Answer. Hypophosphatemia, hypokalemia, and hypomagnesemia. Question. Why does hypophosphatemia occur in refeeding? Answer. Glucose stimulates insulin release, which drives phosphate into cells for anabolic activity. Question. How should you manage a patient with a high gastric residual volume? Answer. Hold feeds, check tube placement, elevate the head of the bed, consider prokinetics, and if persistent, consider post-caloric feeding. Question. What is aspiration pneumonia and how can it be prevented with enteral nutrition? Answer. Aspiration pneumonia is the inhalation of gastric contents into the lungs. Prevention includes elevating the head of the bed, using post-caloric tubes in high-risk patients, and monitoring for intolerance. Question. What causes tube feeding clogging and how is it managed? Answer. Clogging is often due to formula or medications. Prevention involves flushing the tube, and unclogging may require water, enzyme solutions, or devices. Section 7. Formulas, additives, and pharmacology. Question. What is the difference between a standard polymeric formula and a peptide-based one? Answer. Polymeric formulas contain intact proteins and require normal digestion. Peptide-based formulas have partially broken down proteins and are used for impaired gut function. Question. What is the purpose of fiber in enteral formulas? Answer. Soluble fiber helps manage diarrhea, while insoluble fiber adds bulk and helps with constipation. Question. When would you use a renal-specific formula? Answer. For patients with end-stage renal disease on dialysis. These formulas are concentrated, lower in potassium and phosphate, and have a specific protein profile. Question. When would you use a pulmonary-specific formula? Answer. For patients with chronic obstructive pulmonary disease and high carbon dioxide levels. These formulas are lower in carbohydrates to reduce carbon dioxide production. Question. What is the role of arginine? Answer. Arginine is a conditionally essential amino acid that supports immune function and wound healing. Question. What are branched-chain amino acids? Answer. Leucine, isoleucine, and valine. They are metabolized in muscle and used in liver failure formulas. Question. What is the role of prokinetic agents? Answer. Prokinetic agents promote gastric emptying and intestinal motility. Examples include metoclopramide and erythromycin. Question. Why should certain medications not be crushed and given via feeding tubes? Answer. Extended release or enteric-coated medications can be unsafe or ineffective when altered. Alternatives should be sought. Question. What is the major drug tube feeding interaction for phenytoin? Answer. Enteral formulas can bind phenytoin and reduce absorption, requiring adjustments in timing and monitoring. Question. What is the major drug tube feeding interaction for warfarin? Answer. Enteral formulas often contain vitamin K, which can reduce the effectiveness of warfarin. Consistency in intake and close international normalized ratio monitoring are required. Section 8. Ethics, Economics, and Practical Management. Question. What is the ethical principle of autonomy in relation to nutrition? Answer. A patient with decision-making capacity has the right to refuse nutrition and hydration, even if it will lead to death. Question. What is the difference between withholding and withdrawing care? Answer. Ethically and legally, there is no difference. Withdrawing a therapy is no different from not starting it. Question. When is nutrition support considered futile? Answer. When it cannot achieve the goal of improving the patient's quality of life or prognosis, such as in a terminally ill or imminently dying patient. Question. Why is enteral nutrition cheaper than parenteral nutrition? Answer. Enteral formulas are less costly, and enteral nutrition avoids the expenses and complications of central line care. Question. What is the role of the registered dietitian on the surgical team? Answer. The registered dietitian is essential for nutritional assessments, calculating needs, recommending the route and formula, monitoring tolerance, and educating staff and patients. Question. What does trophic feeds mean? Answer. Trophic feeds refer to a small volume of enteral nutrition intended to stimulate the gut, rather than meet full caloric needs. Question. When should you consider a percutaneous endoscopic gastrostomy tube? Answer. For patients who will need long-term enteral access due to a functional gastrointestinal tract but are unable to eat orally. Question. What is the window of opportunity for initiating nutrition support? Answer. The first 24 to 48 hours after major surgery or insult. Early nutrition is associated with better outcomes. Question. How do you transition a patient from parenteral nutrition to enteral or oral diet? Answer. Gradually. As enteral or oral intake reaches 60 to 75% of needs, parenteral nutrition can be decreased and discontinued. Question. What is the single most important take-home message for a surgical resident regarding nutrition? Answer. If the gut works, use it. Early enteral nutrition is a proactive therapy essential for improved surgical outcomes. Screen for malnutrition early and include the dietitian. Thank you for joining today's podcast on surgical nutrition. Stay tuned for our next episode, where we continue to empower your clinical knowledge. If you enjoy the content, please like, share, and subscribe. It's the Everything Surgery Podcast. Dissect the extraordinary.